Actually, the commonest cause is likely musculoskeletal, that is to say, a strain of either the tendon or the joint in the ribs and sternum, or indeed from the back spine in the chest, which radiates into the front of the chest. And very often it can, for the patient, immediately trigger concern that it might be in some way cardiac, and specifically an artery block. But actually, for every 10 patients with chest pain presentation, one might find at least 7 or 8 of them have a relatively innocent cause. The other causes that we need to consider are primary heart muscle conditions, or the lining, outside lining of the heart called the pericardium, where sometimes chest pain can be thought of as an artery block, but in fact due to other conditions in the heart than artery blocks. But the commonest cause of chest pain, which is needing to be treated, and which can, of course, cause major health problems and shortening of life, is coronary artery disease, which, if it progresses to a full occlusion of the coronary artery, can lead to myocardial infarction and all the dreadful complications of that condition. But it's very important to remember that most chest pains are not of that type. Nevertheless, anything that is central in the chest is a feeling of a tightness, and certainly in any way related to exercise rather does demand immediate attention. And sometimes also coronary disease is a bit variable in its presentation. So everyone is going to be different and describe their pain in a different way. So thus, chest pain in a patient really should be pursued in terms of further referral to a person expert in the field. And I'd like to think I'm an expert in that field. The symptom of chest pain is best first assessed by the history, and the history is taken in order to look at whether or not an artery block is at the cause of the chest pain. The history will then be followed by the examination to exclude blocked valves or an irritation around the outside of the heart called pericarditis. And the test would be fundamental electrocardiogram, perhaps with an ultrasound test of the heart, and certainly with other investigations, including a test of supply and demand for the heart, typically best examined by an exercise test on a treadmill or bicycle protocol. Other more imaging modalities are then offered, including direct coronary angiographic study or CT coronary angiogram or MRI study if the diagnosis is still unclear on the basis of these basic tests and the symptom. The treatment options are firstly, usually reassurance that the pain is not from the heart. And that's a combination of the story and some of the basic tests. Thus, the treatment option of reassurance is on that basis of the symptom and basic tests. But if the symptom is more worrisome in as much that it might be due to the shortfall between supply and demand of the heart because of coronary artery narrowings, then the treatment options can be medical. But in the first instance, it is wise to look at the anatomy with a coronary angiographic study to assess whether there's a potential threat at present or in the future, in which case balloon angioplasty is now regarded as pretty much the standard intervention, and that can be offered with a range of serious artery blocks using stents and other contemporary investigations. Finally, of course, be it an artery block or a valve condition, surgical therapies are available, and we have at the HCA a wide range of truly expert people in those individual fields. The lifestyle adjustments and preventative measures for chest pain obviously depend on the cause, but assuming that there's a cholesterol background where there may be options for reducing the total cholesterol and limiting the disease within the coronary arteries, these lifestyle adjustments are clearly weight reduction and exercise capacity, calories in, calories out equation. So reducing one's total calorific input by a variety of contemporary diets, many of which can be advised, and secondly, by an exercise regime to suit the patient. One has to be realistic, of course, and not set impossible targets for weight reduction, nor impossible targets for exercise capacity. But these are the principal adjustments. Of course, we see still smoking as a major risk factor, and if there is a smoking history, then obviously that needs to be addressed. Again, however, one has to be realistic in one's approach to smoking habits, and some patients find it very difficult to limit their cigarette intake, but less is more, if you like, and giving up smoking is obviously a difficult task, but essential in the suspicion of a patient who has coronary artery issues. If the chest pain is more likely to be due to musculoskeletal issues, again, weight reduction and exercise regimes and other more holistic approaches are very valuable in such patients.